All right, so I'm Ron Lasley. I'm a physical therapist. Been specializing in the Schroth method since 2015 as we began the program here at Norton. Just to go ahead and say there are no conflicts of interest or relevant financial interests by the faculty or planners of this activity. There is no commercial support of this activity. So Dr. Nixon shared some of the definitions of scoliosis. I'll share a few and then what I feel like are more appropriate definitions. So scoliosis is a sideways curvature of the spine that occurs most often during the growth spurt just before puberty. That's from Mayo Clinic. Scoliosis is a general term used to describe any lateral curvature of the spine. Scoliosis is a lateral curvature in the normally straight vertical line of the spine. I feel like these definitions probably are more fitting. Complex 3D deformity of the spine and the trunk involving morphological as well as geometrical changes not yet well understood. Another one is a complex 3D deformity of the spine and trunk, which appears in apparently healthy children and progress in relation to multiple factors during any rapid period of growth or later in life. The Schroth method actually originated from Germany. Katharina Schroth was one of the founding individuals that started the methodology. She had scoliosis herself. She had some braces. Of course, you can imagine back in the 1920s, 1940s, what those braces probably look like. But bracing was not effective for her, and she did some research on her own and developed the Schroth method. She had a couple of daughters that also became PTs and took that method and developed it. And it's been in Germany for quite some time, like I said, since 1920s. And it's just recently in the last 10, 15 years kind of made its way here into the United States. You can see in the 1960s, her daughter, Krista Lienhardt Schroth, again, a PT who helped further develop this method. 1990s, about 3,000 PTs per year, or I'm sorry, 3,000 patients per year. It was an inpatient model in Germany. Her grandson, Dr. Weiss, I believe is his pronunciation, was the medical director. In 2008, it changed to the ASKS. It became more of an outpatient model there in Germany. And the Schroth name was legally registered in Germany at that time. Alina Salva, PT, she was friends with Schroth. She trained under the Schroth method. 1980, Dr. Manuel Rigo married Elena Salva's daughter, Dr. Gloria Salva. Dr. Rigo trained in Sonderheim with the Schroth method. And then in 1989 to 2008, Schroth-based courses for PTs in Barcelona were developed. First US PT courses in 2005 on this methodology. Barcelona Scoliosis Physical Therapy School, which also known as BSPTS, was founded by Dr. Rigo in 2008. It was approved by Krista Lienhardt Schroth, and it is a 3D treatment of scoliosis according to the principles of Katharina Schroth and also Krista Lienhardt Schroth. The pictures below are a group of the individuals that are trained. So I think the ones on the left here of my screen, I believe that those are more international instructors, and then the American instructors are located on the right, I believe. 2011, the first meeting of the International Body of Instructors, Barcelona, Israel, and USA instructor groups. 2013, US forms a cooperative for the courses for scoliosis education seminars. The BCS-PTS strives for a deeper understanding of the deformity. A deeper understanding of the deformity is a driving force. You also have the SORSORT, which is Society of Scoliosis, Orthopedic Rehabilitation and Treatment. That was founded in 2004. It's multinational, multidisciplinary, non-surgical focus, early intervention, and they do have annual meetings. I have yet to be able to have the opportunity to attend one of the meetings, but hopefully soon we can work out something with Norton for me to be a part of that. Treatment guidelines, it's a challenging question. Is observation really treatment? Is bracing alone too passive? Can earlier interventions help prevent surgery? Is surgery a worthwhile trade-off to the deformity? These are just some guidelines here as to, this is what Scoliosis Research Society and the SOSORT group, their guidelines, you can see them side by side based on the Cobb angles. I won't go into that in detail. You can kind of hopefully look at that later, and it just kind of gives you a little bit of a guideline as to when certain treatments are utilized at the time based on the Cobb angles. Parents, a lot of times it's too much wait and see. Patients, you have a lack of empowerment on how to help themselves beyond bracing and waiting. Therapists in the past, especially in the United States, unfortunately, has been inadequately educated and equipped for scoliosis treatment. Orthotists, traditional braces lacking three-dimensional corrections, producing flat back or other poor cosmetic changes. For doctors, is there a way to help patients sooner? Is there another option to an orthopedic surgeon referral? And when is, surgeon referral when surgery isn't likely? Dr. Nixon touched on the brace study, so I probably won't go into a whole lot of this. I'm just going to kind of go into what the results were, and that is the trial was stopped early. Same thing that Dr. Nixon said, due to the efficacy of the bracing. An analysis that included both the randomized and preference cohorts. The rate of treatment success was 72% after bracing as compared with 48% after observation. Again, this information, as I listened to Dr. Nixon give her presentation, it's all repeat. So you can go through that and read that later on if you want as well, but Dr. Nixon did touch on this already. The conclusion was bracing significantly decreased the progression of high-risk curves to the threshold for surgery in patients with adolescent idiopathic scoliosis. The benefit increased with longer hours of brace wear. I believe the study was funded by the National Institute of Arthritis and Musculoskeletal and Skin Diseases and others. Take-home points of the bracing. Dr. Weinstein reported that bracing of adolescents with moderate scoliosis was effective treatment in the reduction of the number of patients who advanced the need for surgery. In addition, positive dose response effect was found between the number of hours of brace wear with the success rate of bracing. The SRS website, bracing found to be an effective treatment for idiopathic scoliosis. Treatment success achieved by 72% of the brace wearers. Dosage, the rate of success achieved by those patients who wore the brace for 13 hours or more was greater than 90%. I think that's a pretty significant number. Bracing is an outside force acting on the patient's spine to reduce the risk for progression in adolescents at high risk of progression or surgery. Scoliosis specific exercise is another outside force directed by a skilled PT through trained and correct exercises. Main indicators for the Schroth method are adolescent idiopathic scoliosis. Others include congenital scoliosis and deformities in the sagittal plane, such as your Sherman's disease, hyperkyphosis, and hyperlordosis. Risk of progression: the younger and more skeletally immature the patient and the higher curve at diagnosis, the higher the risk of progression. The higher the risk of progression, the more intense the conservative treatment plan should be. Conservative management professionals should try to determine the risk of progression as a means of designing an appropriate plan of care. Plan of care should avoid both undertreatment and overtreatment, if at all possible, which sometimes is difficult to do. Won't spend a lot of time here. These are just talking about absolute progression. Most of you are probably very familiar with that, relative progression. Obviously, one of the things to consider is 2 consecutive increases of greater than 3 degrees in 2 periods of 3 months would be considered relative. And then also greater than 10 degree Cobb in 6 months is absolute relative progression. I'm going to go ahead and just go past this area. Again, that can be read later. So how do we predict risk of progression? It's the Cobb plus other variables. So your primary is Cobb angle, current patient age, your RISR score, which for anybody that doesn't know, that's measured at the iliac crest. The secondary is your age of the patient first diagnosed. Menstruation, growth can occur now for up to 2 years post menstruation. Family history and additional morphologic and radiologic characteristics. I don't know if there's anybody on here that doesn't know what the RISR sign is, but just in case there is, the RISR score trumps age of the patient. This definitely is nice to have from a radiologist standpoint, although I can read this as well. Sometimes it's difficult to see, so anytime I can get URALs, Dr. Nixon, Dr. Walker, Dr. Meyer, anytime you all can contribute to a RISR score, it's also helpful for me, especially on those x-rays that are diminished in their clarity. Again, just another thing that kind of helps, another way to help determine what the risk of progression is, and you can kind of look at this and go through it and decide and kind of just analyze this yourself on your own if you want. So in my PT clinical evaluation, I like to observe the general clinical posture. A lot of times for myself, I like to look at the clinical presentation before I even look at the x-rays. And then I like to go back and see if the clinical presentation is telling me close to what the radiological presentation is telling me. So a lot of times parents come in and they wonder if I've looked at the x-ray yet. And for the most part, I tell them I have not yet, but I will spend sometimes close to 30, 40 minutes looking at those x-rays as I write up my evaluation, just to see how close it looks to the clinical presentation. I do a sagittal inclinometer. I also do a plumb line. I look at the Adams forward bend. I look at the seated scoliometer. I typically use seated scoliometers, the ATRs, more so than standing. I also look at respiratory when I feel like that's an issue. So I observe the breathing patterns, measure inspiration circumferences, measure expiration, and then also inspiration volume. Then as I look at the radiological evaluation, I look at the sagittal and frontal views when they're available. I look at the central sacral line, comparing that central sacral line on the x-ray to the one that I typically do clinically. I look to identify where the apex levels are. I look to identify upper invertebrae, lower invertebrae. I define the Cobb degree. Typically, I find that most of the time we're very, very close to each other in our measurements. I don't think I've had any measurement that was really off. Look at the transitional points and also where the T1 is located in reference to that, that central sacral line. I look for counter tilting, typically seen at L4 or L3, L4, L4 and L5. And I also look for what we classify in this methodology as an upper curve, a demodifier. I look at the RISR score, and then I look at any other pelvic obliquities, listhesis, anything that I can identify that would be something I would need to be cautious with. Screening methods, when I go out in the community, I always look at Adams forward bend test. I always take my scoliometer, have it with me. You do have to be a little bit careful when you're using your scoliometers, that maybe if you have an app on your phone, because your phone doesn't contour to your spine, and typically you're taking that scoliometer that U-shaped area, then you're running that down the spine itself. So on your phone, you don't have that. So your degrees of rotation can be off a little bit when you're using your phone. So I typically always have a scoliometer with me. And then I also look at the torso asymmetry. This is just showing what I typically will look at in a screening. If I have a posture good to go by, I usually have them stand in front of that if I'm somewhere where I'm doing this for somebody. Sometimes I'm involved in helping with sports and athletics and screening these. So again, I look at the view from behind, and I also look at the side view to see if there's any disruption in the arc of flexion. And where is that arc of flexion disruption at? Again, I typically always go by seated scoliometers, kind of get the legs out of it, especially if I'm detecting a potential for a leg length. So I always try to compare standing to sitting to see how they compare. Definitely, I'm always looking at how much rotation is going on and what levels that apex is at. I try to identify those apex levels, actually, even before I see the x-ray. Looking at torso deformities, looking at how their body presentation is, how their clinical presentation is the trunk listing to the left or the right? Is the pelvis listing to the left or the right? What's the sagittal view look like? Is there a negative sagittal balance, a positive sagittal balance? What are other contributing factors that need to be addressed other than just the frontal plane deformity? Typically, in this methodology, we define our treatments as curve classifications. We have different groups of curve classifications. We have what we call the sagittal plane deformities. So those are things like your hyperkyphosis, your Sherman's kyphosis. We have our single thoracolumbar or single lumbar curve classifications. Those typically are going to be, even if they have just a single thoracic, if the apex is at T8 or T9, we don't have a single thoracic classification. So it either has to, the apex either has to be at the thoracolumbar junction, either T12 or L1, or it has to be in the lumbar area to be classified as a single thoracolumbar or a single lumbar curve. We also have the group 2, as you can see, there are deformities in 3 planes, and that's classified as a 3 curve, 4 curve, non-3, non-4. So whenever you guys see my notes, if you see that I'm saying a patient has a 3 curve pattern, I'm not necessarily saying that they have they actually have 3 curves. They may only have 2, they may actually only have 1. But what you're looking for is what's involved. Are the shoulders involved? Is the thoracic block area involved? Is the lumbar involved? Is the pelvis acting independently from the lumbar curve? And that's where you get your different curve classifications. So your 3 curve classification is typically you have shoulders involved. You have a thoracic curve that's typically bigger than a lumbar curve if it's present. In a 4 curve, what you typically see with that is you'll see a thoracic curve, you'll see a lumbar curve. The lumbar curve is typically bigger than the thoracic curve, not always, but typically. But then the pelvis is actually shifting away from that lumbar curve. So it becomes a separate entity that needs to be addressed as well. And then you have your non-3, non-4. So that means that patient does not fit a 3 curve pattern or a 4 curve pattern, but they may have 1 or 2 curves. So if you had somebody that had an apex, a single curve, but the apex was at T8, they'd be classified as, and if their shoulders are balanced over their pelvis, then they'd be classified as a non-3, non-4 with or without lumbar, depending on if they have a lumbar curve. So again, those are important from my perspective, from just helping me to define what treatment exercises I may give this patient. There are some exercises you do not want to give to somebody who is a 4 curve that you might do with a 3 curve because of what's happening at the pelvis. So that's why this is important to me, and that's why you'll see that on my evaluation. Again, these are your sagittal view deformities. You can see those different ones there, the increased lordosis, your increased kyphosis, your flat back, and then of course your sway back. All those can also be addressed through this program. This is going into a little bit, giving you a little bit more of a visual of your different curve patterns. So this is a single thoracolumbar curve. Again, the apex of that curve is at the either T12 or L1. The blocks here, I think, are a little bit easier for the patients to understand what they're seeing and what we're working on. So I utilize these blocks, the picture of these blocks, and then also try to come up with a picture of how we classify the radiological classification as well as the treatment curve classification. So I give that to the patient, show them that so it helps them understand what we're trying to work on. This is just showing your single lumbar curve. So the apex is lower than L1. So apex is going to be either L2, L3, or if it's L4. And again, the blocks just kind of show you what that also looks like, a little bit different visual for the patients. This would be a 3 curve. So again, you can see that there is a, not really much of a lumbar curve there. Primarily it is a thoracic curve. But this patient also has a bit of a demodifier, which is what we refer to as that additional curve up higher around T4, T5 area. And with this 3 curve pattern, you can see how the central sacral line, the T1, is running down on top of that. It's on the line, the central sacral line, but then the transition points lying to an opposite. It could be either left or right, just depends on which way the curve's going. So again, we use the blocks here to help the patient understand what's going on with their spine. This is a typical 4 curve x-ray, what one looks like. So again, your central sacral line, your transition point, your T1 typically are always to the left of that line, or if their curves are going the opposite way, it would be to the right of that line. But you can also see the pelvis here is shifting over towards the right. You'll definitely see that clinically many times. And again, that lumbar curve is typically going to be bigger than the thoracic curve. Not every case, but for the most part it is. Here's a little bit, another 4 curve. This is a different radiological classification. You can see they're a little bit further away from that central sacral line with a T1 and the transition point. So there's probably a little bit more shifting of that pelvis going on. And then we're also looking for, again, counter tilting. And typically you'll see that counter tilt. You can kind of see it in this image up here as well. You can see that counter tilt down there at I believe L3, L4, maybe even L4, L5, but definitely L3, L4. This is a non-3, non-4. So you can see the central sacral line. The T1 is running down through, is on that line. And then also the transition point is on that line. Typically this patient presentation is the shoulders are balanced over the pelvis. Everything is in line. And even clinically, you'll see that when I do the laser down their back, it'll go from basically T1 all the way down through the gluteal fold or gluteal cleft. Again, this is just another non-3, non-4 with a demodifier. This is a guideline I use from SORT. This was from 2011. I have this after going to one of the courses. This is something they give us that helps us to recommend treatment and so forth. So I kind of just use that. You can look at that later and see how that's written up. You have your infantile, juvenile, and adolescent, and then your different Cobb angles there and your modifiers, and you see your Risser sign. So all that's there to help you guide through. The SB there is a soft brace. Then you have the FTRS, which is full-time rigid bracing, FTRB, sorry, full-time rigid bracing. Then you have your exercises, EX, and then of course you have observation in most of these cases. But so this is something maybe if you want to look at later, if you have questions about, you can always contact me and ask me about it later. So the goals of rehabilitation from 2011 and the SORT guidelines is to obviously stop the curve from progressing. are to stop curve progression at puberty, possibly even reduce it, help family, patients cope with the deformity, to prevent or treat respiratory dysfunctions, to prevent or treat spinal pain syndromes, and to improve aesthetics via postural correction. That's probably a big one we really work a whole lot on, is trying to help the patient, if they don't already see it, identify the postural asymmetries. Then we want to diminish the functional limitations. And then if we can, we want to prevent surgeries, but we know that in some cases that's going to occur. And I even have some patients come to me knowing that they are going to have surgery, but maybe they just want to try to get through high school, or maybe even try to play collegiate ball. I had one patient that came to me from up around the Northern Kentucky area. He had a 56-degree curve in his thoracic. I think the apex was around T7, T8, if I recall. Quite a bit of asymmetry going on up in that shoulder. His goal, his family played football for high school, and several brothers played football in college, and his goal was to at least get through high school before surgery, maybe even play collegiate ball if the curve didn't progress too much more. So I worked with him very closely for about 2 years to get him through. He came to me as a freshman in high school. We got him through 4 years of football, kept his curve progression slow. He was a very hard worker, but ultimately the curve progressed into the 60s, low 60s, around 60, 61. And he was a senior. Football season was over, and he just decided at that point it was time to go ahead and have surgery. And then his goal changed from playing collegiate ball. He was going to still go to college and get on a football team, but to learn the coaching styles and coaching techniques. So just had a little change of what his goal was going to be. But we kept him at least in football through his high school years. Had another young lady that came to me with a 42-degree curve as a freshman in high school, softball player. She was on the news not too long ago. Her and I were. You may have seen that. I don't know if you did or not. But her goal was to try to avoid surgery, get through high school, but then go to college to play ball. So we were able to achieve that goal. She works an hour a day, 5 days a week on just her Schroth exercises, along with everything else she does for her softball. She signed with Brescia College. She is now a freshman pitching for Brescia College. Again, she had a 42-degree curve when she came to me. Her most recent x-ray was 29 degrees. So she's just a very hard-working young lady. And she has kind of shown us that in some cases, improvements can be made, whether it's postural, is yet to be seen, if it's just postural, or if it's just that she's really gotten good at training her muscles on how to help her spine. All right, principles, won't go through all of that. We're going to kind of get close to an end. I'm pretty close to being at the end anyways. This is just showing you some of the equipment I use here. It's a wall ladder. We call them wall bars, stall bars, Schroth bars. You hear different terminologies. So I can utilize this for hanging, which is allowing for good 3D stretching of the spine. And of course, a lot of other different exercises based on their curve pattern. Again, these are some of the exercise positions you'll see us put people in. This is 2 of my patients that began with me early on, probably 2 of my first patients. Both were sisters. One had a single thoracolumbar curve, which is Maggie on the right. The other had a 4 curve pattern. So she actually had 2 curves, a thoracic curve and a lumbar curve. They both went through the program for 2 or 3 years. Both were successful in being able to avoid surgery, and both curves stabilized and progressed no further than when they came to first see me. These are just showing some different positions I had them in. They are probably a little bit more advanced than most of my patients, but they worked really hard, and I was able to do some fun things with them. Again, just some different positions: side lying, standing, utilizing poles, hanging exercise. This is another young lady, but I won't go into detail on her. We'll save that for another time. Again, just showing some different exercise positions based on her curve pattern. She's actually a 3 curve, so I can do some overcorrection with her as I'm treating her. And this is just my backyard. So that draws up to an end on this. We can come to in a time if you have any questions.